My name is Toni Esselin. I'm currently serving as the Deputy Chief Medical Officer, and we're excited to bring you some updates today from the CMO office, as well as giving you an update on what's going on with tuberculosis. First, I want to send it over to Priscilla, who's going to give you some information about today, and then we'll get started.
Hi, everyone. Thank you, Toni. Good morning. I'm going to quickly go over some general information related to continuing education credits. Rutgers is providing 1 CME credit for physicians that attend this entire webinar. Next slide, please. In order to claim your credit, you must complete the evaluation survey. A link will be shared in the chat by email after today's session and can also be scanned through the QR code on the screen. The evaluations must be completed by next Friday, July 18th. If you miss this deadline, you won't be able to claim credit for this activity any longer. Please expect to receive your credit letter within 4 to 6 weeks after today. If you have any questions about CE credits, just feel free to contact me. I will also leave my information in the chat. Thank you, and I'll turn it back over to you, Dr. Toni.
Thank you so much. So today we're going to give you some quick updates from the Chief Medical Officer's office, and then we're going to have Dr. Brzezinski talk to us about an update on tuberculosis. But before we do that, and then after that, we're going to have our Q&A session for those of you who have some questions. So I'm excited, and thank you again for joining us this early Friday morning in the summer. So we can go to the next slide. I can give you my updates. All right, so just so that you know, the health department is focusing on human papillomavirus vaccine. And the reason is because when we were looking at our data, we find that only 46% of our 13-year-olds in New York City have completed the HPV vaccine by the time that they become 13, right? And so as you can see by the map here, we don't have a lot of coverage, and we're trying to get those numbers up and close that gap as much as possible. Next slide. And so we have launched, as of this summer, this campaign for our providers to really see what they can do for closing the gap for vaccination for our kiddos, mainly because we know that HPV is a very effective vaccine. It also helps prevent HPV-mediated cancers in both girls and our boys. And so it's important for us to make sure that we are offering this vaccine to all our children. And specifically this campaign, you can go to the next slide. Specifically, this campaign is targeting our children to get the first series of the vaccine by the time they're 9 years old, right? So we have found that the opportunity to close the gap and then make sure that our children are finishing the series is the earlier that they get the vaccine. And so we are really recommending and hoping that you all can encourage your providers in your systems to start recommending the vaccine at age 9. As a reminder, we recommend that children ages 9 through 12 get the vaccine. Anybody who has gotten 1 or 2 of the vaccines and they haven't completed the whole series, we ask them to go ahead and try to complete that series for them. Make sure that anyone who's an adult from the ages of 27 to 45 who didn't get all the doses, try to catch them up to get all of those doses. And remember that anyone that's under 15 should get at least 2 shots, 6 months apart. And if you're older, you have to get 3 shots over 6 months. And so we're really pushing for folks to close the gap. And please look out to health department press releases, websites, to guide your providers on trying to figure out how in your system you can close the gap for our young kiddos to be protected And so from now, hopefully that was clear. And so for now, we're going to jump into our main event, which is our tuberculosis updates. And so I want to introduce to you Dr. Joseph Brzezinski, who is the Assistant Commissioner at the New York City Department of Health and Mental Hygiene, Bureau of Tuberculosis Control. Dr. Brzezinski received his MD degree from the University of Louisville School of Medicine and his MPH from the Harvard T.H. Chan School of Public Health. He trained in internal medicine at St. Elizabeth's Hospital and infectious diseases at Brown University. He is board certified in internal medicine and infectious diseases. Dr. Brzezinski has worked at the Bureau of Tuberculosis Control since 1995 and has served as Assistant Commissioner since 2013. So without further ado, Dr. Brzezinski, take it away.
All right. Good morning. Thank you, Dr. Estlin, and thank you, everybody, today for joining. We've seen a troubling increase in TB cases in New York City in the last couple of years. We've had a 50% increase since 2022. This may feel familiar to some of you, as in the late 1980s and early 1990s, there was an epidemic of TB in New York City. And as providers across the city, your partnership with us is really essential for us in meeting the challenges that we have in addressing this increase. So today, I'm going to give an overview about our work at the New York City TB program. I'll talk about the 2024 TB surveillance data in New York City, talk about the role of the New York City healthcare system in addressing TB, and finally, talk about some takeaways and resources we can provide and share with you. And then we'll have a little bit of time for question and answer and discussion. So next slide. So first, I'll start with an overview of our TB program in New York City. Next slide. The New York City Health Department collaborates with healthcare providers, laboratories, community-based organizations, and other key stakeholders to deliver our TB care and prevention throughout New York City through a dynamic, integrated approach to core activities and services. Our core activities include surveillance, clinical care, case management, medical consultation, contact investigation, outbreak detection and response, and outreach and education. Next slide. If you look at the map of New York City, we have 3 TB clinics in the city. One is at Fort Greene in Brooklyn. Another is in Morrisania in the Bronx, and then the Corona Clinic in Queens. We provide comprehensive TB services. Our services are free for all patients, and we do not ask any questions about immigration status. Next slide. So I'm going to start with the 2024 surveillance data. Next slide. Here you can see our reports from 2024. We had 839 cases identified. The citywide rate was 9.5 per 100,000. 90% of our cases were in non-US born persons. The majority were in the age group of 18 to 44. And 13 people had multi-drug resistant TB. You can scan the QR code there if you would like to have a full access to the infographic. So I encourage you to do that. Next slide. Here's a graphic of our cases over a 30-year span. You can see that rapid increase in the early 1980s, peaking in 1992, and then a rapid decline after we implemented effective TB control strategies, and also treatments for HIV became a lot better during that time period. Then we had a period where rates generally flattened out. But you can see there at the very end of the graphic on the right-hand side that cases have started to rise again in 2023 and 2024. So the next slide. And here you can see for the last decade, a pretty dramatic increase in 2023 and in 2024. We had a 24% increase in our TB cases in 2024. So that was really dramatic and worrisome. Next slide. Here you can see the distribution by gender, the proportion of male cases was 68%, female 32%, and the majority of cases occur in that age range of 18 to 44 with 54% of our cases. But you can see that we do have some pediatric cases and some cases in the elderly. Next slide. Then if you look at, this really highlights the difference between US-born cases and non-US-born cases. If you look just at non-US-born cases, our rate there is 23 per 100,000, compared to a rate of 1.6 for US-born persons. So quite a dramatic difference there. Next slide. Here you can see TB rates by neighborhood. I think it's important to point out that we do find TB cases in all neighborhoods in New York City. The darker green areas there, those are the parts of the city that are most heavily affected by TB. Thank you. And here, looking at a global map, you can see where people are coming from around the world to New York and have TB while they're here. You can see that the rates of TB in some countries where people are coming from to live and stay in New York are much higher than we have. So very frequently people are infected in their home countries and then later develop active TB once they get here. There were 67 countries of birth represented among the TB patients in 2024. And people are often here for a long time before they break down and develop active TB. It was 12 years was the average number of years that non-US born persons were here before they developed active TB. Next slide. This is looking at MDR TB. Although our cases have gone up, fortunately, we haven't seen a dramatic increase in drug-resistant TB. We had 13 cases of multi-drug resistant TB last year and 1 case of extremely drug-resistant TB. Next. This slide here just highlights the proportion of TB cases and rates by birth in the US and non-US born persons in area-based poverty levels. There's a correlation in area-based poverty levels with poorer parts of the city having more TB in both the US born and in the non-US born. This trend reflects the impact of social and economic factors on TB risk. Housing instability, crowded living conditions, and limited access to health care increase both the risk of exposure and barriers to timely diagnosis and treatment. Next slide. As key partners in this work, I want to use the rest of the presentation to go over how all healthcare providers throughout the city can support us in our efforts to prevent and treat TB and support us in the recent increases. All New York City providers can build capacity for LTBI screening and treatment, especially for the under and uninsured. Report TB cases in a timely, complete manner, and doing so electronically. Supporting public health activities, such as chart reviews as part of our routine case management and nosocomial investigations. And understanding and implementing the new shortened isolation guidelines. Supporting treatment and follow-up for TB patients outside of the health department TB clinics. Next. First, let's take a closer look at building capacity for LTBI screening and treatment, especially for the underinsured or uninsured. Next. To help reduce TB incidence in New York City, you can take these steps to assess and treat for LTBI. Screen for the risk of LTBI in all patients annually using a standardized tool, such as the New York City TB risk assessment. Test patients that meet any of the criteria on the assessment tool using a blood-based interferon gamma release assay test. Next, rule out active TB with clinical evaluation, chest X-ray. Then treat LTBI using a short course regimen, such as 3 months of isoniazid and rifapentine or 4 months of rifampin, and counsel patients on treatment adherence. Then report diagnoses of LTBI among children younger than 5 years and potential or confirmed active TB cases in people of any age within 24 hours to the New York City Health Department. You can scan the QR code here on the screen to view our Dear Colleague letter. Okay, next slide. Who should be tested for TB? Well, anybody with symptoms of TB should be tested for TB. Then also, after exposure to someone with known or suspected TB, anybody with a history of HIV, AIDS, cancer, immune disorder, or those who are taking immunosuppressive medications. And also, everyone who is born in a country outside of the United States, coming here from Africa, Asia, Mexico, Central, South America, Eastern Europe, should have at least one TB screening test with a gamma interferon release assay. Next slide. So for the treatment of latent TB infection, once TB is ruled out with a clinical evaluation and X-ray, LTBI should be given to most patients, especially those who are at high risk for developing active TB, especially those who are recent contacts of persons with infectious TB, or people living with HIV, patients with organ transplants and other immunosuppressed patients, and persons who have suggestion of old TB on their X-rays. Next. Just going to briefly describe the various treatment regimens for latent TB. We do prefer the short course regimens. So in our clinics, we mostly use isoniazid and rifapentine. This is a once weekly regimen for a total of 3 months. We also use rifampin daily for 4 months. Some places are using isoniazid and rifampin for 3 months. We don't use that often in our clinics. And then finally, for patients who cannot take rifamycin, one option is isoniazid for 6 months. Next slide. You can use the QR code here if you would like more information on our latent TB infection toolkit. This is information for providers, and there's also information in these toolkits for patients taking treatment for LTBI. Next slide. The next key area is timely and complete TB case reporting. I will go over a few reminders about what and how to report. Under the New York City Health Code, all suspected or confirmed TB cases must be reported to the health department within 24 hours. This applies to healthcare providers, infection control practitioners, hospital administrators, laboratories, and pathologists. Next slide. Non-laboratory reporters must submit a universal reporting form, preferably electronically. Positive NAA test or positive culture for MTB complex, positive AFB smear results, TB consistent pathology or autopsy findings, clinical suspicion with initiation of treatment, any other high clinical suspicion of active TB, and children under 5 with a positive test, either a TST or an IGRA test. Next. Laboratories should report the following through the eClear system: a positive AFB smear, positive NAA, drug susceptibility results, all subsequent diagnostic results within a year of a positive test, and all IGRA results. Next. So we did make some changes to our pathology reporting criteria. This was in an effort to try to streamline so that we can receive only the most important and most likely to be active TB cases. So the new requirements include reporting pathology specimens that have the presence of AFB, caseating granulomas, or caseating necrosis. Next. For discharge and treatment follow-up, patients with infectious TB need the health department to approve the discharge. Discharge requests should be submitted within at least 72 hours before the planned discharge. Treatment updates should be reported to us monthly after the discharge. There's an electronic form submission that's available through the New York City Health Department website. This is for discharges and also for the follow-ups. Next slide. Now we'll look at how providers can support public health activities. That's case management as a pillar of TB TB control in the city. The health department provides case management to all confirmed and suspected cases of TB, as well as contacts who have been started on treatment. Case management activities include interviewing and educating patients about TB, conducting comprehensive review of the medical records, coordinating post-discharge care, monitoring adherence to TB medication, often with directly observed therapy, and then making sure that the contacts are evaluated and placed on treatment. Treating physicians and hospitals are critical partners in case management work, from coordinating the discharge and facilitating chart reviews. So we appreciate all of your ongoing support. Next. Another critical public health function where we partner with healthcare facilities directly is healthcare-associated investigations. The health department is very happy to work with facilities, infection control staff following an exposure to determine the appropriate next steps. This slide shows a breakdown of healthcare-associated TB investigations our team conducted in 2024 by health system and site type. In 2024, we had 94 healthcare-associated investigations. Of these, 74% were in hospitals or clinics. Our expanded contact investigation team is here to work with you in responding to these situations quickly and thoroughly. Next slide. Next, we will review the new TB isolation guidelines and how they should be implemented. So this is the masthead of a publication that was published in Clinical Infectious Diseases about a year ago. This was the work of a guideline development group. I was part of this group, and this was for guidelines for respiratory isolation restrictions to reduce transmission of TB in the community. I would say that this work really came from years of thinking that we really need to consider the effect of isolation on patients and balance that with the needs to protect the public health. I think many people in the TB community came to realize that we were keeping many of our patients in isolation for too long. This work was done by a team of nurses, clinicians, epidemiologists, program managers, survivors, and patient advocates who got together to develop these guidelines. I would say also, additionally, there was some recognition after the COVID-19 pandemic that there was an increased attention to public health interventions and the effect on individual liberties. Next slide. Part of this, when we started this, we thought, well, before we started the work, we thought, what are people doing with isolation practices across the country? And I won't go into this, but the take-home message from this survey was that isolation practices were just different all across the country. There was no real standard, and that can't be a good thing, and it's probably not fair to the patients that are kept in isolation. So next slide. So when we started thinking about how to come up with these guidelines, there were a couple of questions we asked at the very beginning. And these were the questions that informed the recommendations. First, are patients with a higher bacterial burden more infectious than those with a lower burden? The answer to this question is yes. We found this through extensive literature review. Patients who are smear positive are more likely to be infectious than those that are smear negative, those with a positive NAA test, patients who have a cough when they present, and patients with more extensive disease on the chest X-ray are more likely to be infectious. The next question was, once patients are started on treatment, is it still true that patients with a higher bacterial burden are more infectious? And then once you're started on treatment, how long do you need to be on treatment before you're deemed not infectious? So next slide. So I'm going to kind of jump to the recommendations and go through this a bit quickly, maybe in some parts. So first of all, the decision to recommend TB isolation should consider the potential benefits and harm, both for the community and have a consideration for the benefit and harms to the patient. Second recommendation, when you think about TB, many patients can isolate while they're in the community. They don't necessarily have to be in the hospital. And when they're isolating in the community at home, there can be tailored restrictions. That is, it's okay to go outside, for example. You really can't spread TB when you're outside. So if patients living at home and they have a backyard, they can go walk around, be outside. It's a much easier way to spend your time while you're recovering from a diagnosis of TB rather than being in an isolation room in a hospital. This is reminding me to say that patients who are hospitalized do need to stay in an isolation room, and they need to have 3 smear negative results before they can be removed from isolation while they are still in the hospital. The guidelines here are trying to get us to get people out of the hospital quicker so that they can return to the community where there is not the same level of regulations. But while still hospitalized, you have to follow the old-fashioned rules that we've used for 30 years about requiring 3 negative AFB smears. So next. Determining infectiousness and transmission. So prior to effective therapy, as I said, patients with a higher TB bacterial load are more infectious. Once you start therapy, patients start to become less infectious pretty quickly. But for patients who have had less than 5 days of treatment, you have to consider that they could still likely be infectious. But really, after 5 days of effective therapy, most patients can be considered to have a low likelihood of infectiousness or be non-infectious. And that's regardless of their sputum smear status. That is, somebody can remain AFB smear positive if they're taking effective therapy for 5 or more days. They are not infectious in most cases. In conjunction with this assessment, you have to think about where the patient's going to be going or living, who might be around them. For example, as I just said, if you're still in the hospital, if you have to remain in the hospital for some reason, you have to stay in that isolation room because we don't want to have any risk of exposing anybody in the hospital environment. Next slide. So the first point is obvious. For patients without pulmonary TB who have extrapulmonary TB, they generally don't need any isolation. Patients who are on effective therapy in most cases for more than 5 days can be considered non-infectious. And people who still need isolation when they're living at home or somewhere in the community, if they need to continue isolation, there can be tailored restrictions. They can have some freedom of movement. They can have moderate restrictions. Next slide. That's what I just said there for the first one. It's important if you do have someone in isolation to review this frequently so that we don't keep people in isolation for unnecessary lengths of time. And if somebody does have to be in isolation, we should really make sure that we keep that environment as comfortable and supported as possible. Many people live paycheck to paycheck. If they're not going to have money because they're in isolation, we need to try to figure out ways to provide help to those patients so that they can continue to have necessary food and shelter and provide for their families. Next. This is a diagram, a flow chart that we have developed. It's just gotten its final approval. So we're going to be distributing this pretty soon. It's going to be in our new manual, but this will walk you through the various options, thinking about if you have a hospitalized patient with AFB smear positive TB, how soon can you get them out of the hospital back home? For many patients, that'll be quickly. And then even once they're home, many patients will be able to go back to work or school in a quicker amount of time than we used to recommend. Okay, next slide. I've given this talk about isolation quite a few times because I was on the guideline development panel. And I'm often asked, well, is CDC going to make these recommendations that you're recommending to try to get people out of isolation quicker? And the answer to that from CDC was, well, we really can't do that. We have this review process here that would take about 10 years. So we didn't want to do that. We thought this was important to get these out before CDC could make their own official recommendations. But this was kind of a compromise with CDC. Two of their medical officers wrote an opinion piece in the same edition of Clinical Infectious Diseases, where they looked at the article, reviewed the evidence, and came up with a commentary that generally supported everything that was in the guidelines. So this is kind of a way of CDC saying that they support this work. Next slide. So the implications for New York City providers, most patients can be discharged from the hospital sooner than our previous practice. Some important components of this process are timely reporting of cases, submitting a hospital discharge approval form, and arrangement for follow-up appointments and adequate medication until the patient can have their first appointment, and an enrollment into directly observed therapy, which is the work that's done on our part. Next slide. So, in summary, all New York City providers can support treatment and follow-up outside of the health department clinics. This is just looking at what we have done in our TB clinics. As I said, we have 3 TB clinics. We see patients with active TB and latent TB infection. Our Fort Greene clinic is the busiest, and then Corona and Morrisania see the majority of the other patients. So we see about 50% of the active TB patients in our clinics, but there's no way we can see all of the patients across the city. So we have important partners throughout the city taking care of active TB. Dr. Carolee Kaplan-Shaw is on the call. She's a very important ally for us at Bellevue. They see many of the other patients. The clinic at Elmhurst is very busy. And really, we have other partners around the city that help us with this core TB clinical work. Next slide. So these are the important take-home summary messages. Think, test, and treat TB. Assess people at a high risk that are at high risk for TB signs and symptoms of TB. Properly evaluate and treat people with active TB. If you're going to test for TB infection, we really prefer the blood-based test, the IGRA test. Treat people diagnosed with TB infection with a short course regimens. Report suspected and confirmed cases of TB to the health department, as well as TB infection in children 5 and under, or under 5. And call the TB provider hotline for questions and consultation. Next slide. So we're going to go to key takeaways. It's really important for us, the partnerships across the city, to develop this increased capacity to test and treat for latent TB infection. Please remember, as you always do, to report TB cases in a timely and complete manner electronically if possible. If we need to come to the hospital for chart reviews, we hope that that will be as easy and smooth as possible. It's important for our work. Remember the isolation guidelines. I think it's a nice manuscript to review if you would like. There's a lot of information in there on why we made those decisions. But people will be getting out of the hospital quicker than they used to. And then finally, supporting the treatment and follow-up of patients across the city outside of our TB clinics at the health department. Next. So the key takeaways: as TB cases increase in New York City, it is really important to think of TB as diagnosis is still missed sometimes when patients present to the hospital, and assess those at high risk for TB, for signs and symptoms of TB. We're all partners in this work. Thank you for helping us build capacity to prevent and control TB in New York City. Remember to report to the health department. Help us support public health activities and consult with us as needed. So now I'm just going to share with you some additional resources. You can use the QR code here to gain access to this manual. We have it electronically here, and you can find this on our website at the health department. That's our program manual, our 5th edition. We're going to be coming out with a 6th edition soon that will have some updates on treatment of MDR and also the new isolation policies. Next slide. We do have a coalition for a TB-free New York City. In general, we meet about quarterly. The next upcoming meeting is August 15th. We invite anybody to participate, to join us in this coalition for TB-free New York City. We discuss various matters about TB control. And we really, for this to be an effective coalition, we need partners from across the city. So please join us if you can. Next. And here's just some information. Remember, think TB. If you ever want to call us, we're available, working hours. Call the TB hotline at the number listed there on the screen. We also have a great website at the New York City Department of Health website. Look for the TB section. You can find a lot of information about our program and join the coalition. And if you want us to come out and speak to providers at your hospital, we'd be glad to do that. Next slide. So thank you, everybody. We really, really cannot do this work without all of you providing us assistance throughout the city. That's how we managed to get this done. And thank you all for your help. All right, we are moving on to questions, I think. And Priscilla, do you have some questions in the chat, or are people gonna just pop up and ask questions?
Well, I have a sort of a procedural question. I came in a few minutes late, and I would like to be able to access the entire presentation. And how would that be available? And will we be notified about how that will be available?
Priscilla, do you have that answer? I know it's recorded and it's available in some way through the recording.
I can respond. Oh, okay. I can respond. Yes, we'll make it available. And the CMO office, we're going to go to the CMO office so you can contact them and that will be made available. Also, Priscilla, we talked about potentially also putting it on the site, GTBI potentially. So yes, the answer is we'll make it available and we'll just give us your email address and provide that information and we will make sure to get it to you.
Actually, I would suggest that the same way you distributed the notice about the meeting, you could use the same mailing list to distribute the availability of it as a recorded item. So might make it simpler.
So we should have your information then, so that's fine.
Hi, it's Tony again. Yeah, the CMO office will distribute the recording for you all through the same listserv. So we'll make it available.
Great. Thank you. So now we're on to our question and answer session. I understand that Sarah Fan, you had a question about LTBI. Would you like to unmute and share that question?
Sure. So I work in outpatient primary care, so I do see a lot of patients who come from another country and test positive on their quantiferon testing. So for those with latent TB, is it recommended that they obtain routine updated chest X-ray after treatment? If so, how frequently? And are these recommendations different for healthcare workers?
Yeah, so after treatment, there's no recommendation for follow-up X-ray. Once somebody has taken treatment, the risks of developing active TB is very low. So there's no recommendation for routine follow-up X-ray, and that's true for anybody, including healthcare workers.
Thank you. And I have a follow-up question. So I'm sure you've seen this all the time with your own patients. They often have a tough time being compliant with the medication due to the duration of it. Is it still safe to assume that their latent TB is effectively treated if they have poor compliance?
Well, that's a hard one to address. We know that very few people are perfect. So if there's some forgiveness in the treatment, if you get most of the medicine in, you'd greatly reduce your risk of developing active TB. But even this is a bit difficult to convey this concept, but most people with latent TB infection, even if they don't take treatment, they're probably not going to develop active TB. Somewhere between 5 and 10% of people who are infected with TB later develop active TB. So with treating for latent TB infection, we reduce that risk. We reduce that risk quite a bit. But, most people, even who are infected, are not going to develop active TB. So there's really nothing special you have to do. If you think there's poor adherence, you might want to extend the treatment and talk to your patient about the importance of adherence and extend that treatment a bit. But there's no additional monitoring or anything that you would need to do.
Okay. Any additional questions for folks? I don't see anything within the chat, but you all are welcome to unmute as well and ask your question.
As we're waiting for questions, I just did want to thank our partners at the Global TB Institute at Rutgers. They've been great colleagues and supporters of our work, and we do a lot of our talks in conjunction with their center. And thanks to everybody too who helped create this presentation at our Bureau of TB Control.
I have a question. I've asked you this before, Dr. Brzezinski, but just in case anyone else here has had that situation. I had a patient who had a quantiferin test and refused to take the LTPI, the
Treatment.
the prophylaxis treatment, right?
Mhm.
Refused to take the treatment. Said he was going to do his holistic medicine stuff, and then had to come back because of he needed another update for work as a home health aide, and so they were asking for a refreshed, like a new laboratory update, and so it was checked, and then it was negative. And so at this point, what is the recommendation at this point for these forms? If somebody has tested positive, refuses treatment, do we keep rechecking it?
Yeah, so
in this case,
you're fading off there. I didn't hear the end part of your question there, Tony, but it was getting a little staticky. But the quantiferon test is measuring the immune response and the immune response to the specific TB antigens. It's a pretty good test, but it's not great and it's not perfect. And so there are several reasons that you can get these discordant results. One is there's this cutoff of calling it negative or positive. And sometimes when we do the test, the results can be really close to the cutoff line. And, if you drew a test in the morning, you might get a different result in the afternoon. So it's not perfect. It's not a perfect test, but it's pretty good. If somebody tests positive, in general, we say that they're going to continue to have that immune response probably for the rest of their life, or at least for a long time. So we don't recommend repeat testing. If this home health aide had a positive test and had a normal X-ray, refused treatment, and the agency sent the patient back to you, I wouldn't repeat the quantiferon test because it should be positive in the majority of cases. What you would do is you would just take the history and physical and see if the patient has any signs that they could have symptoms of TB. And if they don't, you would just say that this patient doesn't have any evidence of active TB through your history and physical. Some places, we have a standard letter where we say repeat chest X-rays are not indicated just because the yield from that is so low. Someplace is really insistent and they say they're going to fire the guy unless he gets another X-ray, I would probably just do it. But we try to avoid repeat X-rays just because the yield is so low.
Okay, I have one question in our question and answer, and I also know Justin Chan also has his hand raised. So let's take the question from the chat box first. So Dr. Lee Kaplan-Shaw mentioned, I believe you mentioned there is now a way to submit a discharge request electronically. I can't seem to find the link online. So I think we can certainly share that information after the talk as far as resources.
Yeah. I myself don't know exactly where to find it, but we will make sure to send it to Dr. Kaplan-Shaw. Lisa True is kind of the person who has been in charge of that, making the form electronic. And so we'll make sure to have her send it to Dr. Kaplan-Shaw, and then we'll make sure that we can that it'll be more apparent on our website, I guess, so that everybody will have access to it.
Yeah, that would be great, because right now it's either by fax or phone. And, I think everyone would have an easier time if we could do it electronically, just like the reporting. That would be fantastic.
Yeah, I agree. This has just been implemented within the last couple of weeks, so I actually don't know where to find it, but we'll make sure you get it, and we'll try to get it in a more obvious place.
Perfect. And I think what we can do also is we're sharing the slides, we can also share it with this group as well. And to also spread widely. All right, Dr. Justin Chan, please go ahead.
Hi, good morning. I have a question about the updated community guidelines for discontinuing isolation if patients are going to the community. When I was reading that letter, I think I understood that even if patients are being discharged to a congregate setting, it's still the same criteria. I'm not sure if I'm reading it right, or is there anything that is different if someone is going, say, to a homeless shelter or a jail system or something like that?
So there's a bit of nuance and kind of, and this is developed over the last couple of years, I would say, since the guidelines were being published, and then responses across giving these talks, and then also with my colleagues across the country, how should we best handle these situations? And kind of where it's fallen, and you can see this in our flow diagram, is that for somebody who's like got 3+ or 4+ smear positive TB, if they're going back to a shelter, we extend that period of time to 10 to 14 days, just to be like extra sure that the patient's really getting better and that they're on the right regimen, they're tolerating the medicines. We're going to be a little more cautious. And so I think that makes sense, but we're not requiring the patient to be smear negative ×3 before they go back to a shelter. We really feel confident enough that this is all true, that people are not infectious after they've been on medicine for long enough. But because we don't have like a perfect test to say yes, no, we are being more cautious when somebody's going back to a congregate setting.
Okay, so we should be messaging that. Think about this at a minimum of 5 days, but it will be case by case depending on some of these mitigating factors, right? Okay.
Yes.
Thank you. That's helpful.
Exactly. Yeah.
Okay, it looks like we have just a few minutes left. Are there any additional questions? Not seeing any questions. However, I did want to remind you all of the resources that Priscilla shared earlier as far as completing the evaluation for continuing education units. And if there are any questions about that, you can reach out to her as well. And that is due a week from today in order to claim that credit. Okay, no further questions, I guess. I'll turn it back to you, Dr. B, and you can close out the meeting.
All right. So once again, thank you all, our colleagues across the city. It's so important. Our collaboration, that's the only way we can get our work done. We are available. You have a lot of our emails, I think, and the TB hotline. You can call that any day from 9 to 5, Monday through Friday, and get one of our doctors on the line. Or if you need to speak to one of our epidemiologists or any one of our case managers, if you use that TB hotline, you're going to get connected to the right person. And we encourage people to call if we could be of assistance. So again, we know there have been more TB cases in New York over the last couple of years. We think things might be starting to get better now, but it's really through a lot of the efforts that you all have helped us in. So thank you very much.
Thank you.
Thank you.